Test 1, 2. YouTube mic check. 1, 2, 3. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Mic check. 1, 2, 3, 4, 5, 6. Microphone check. 1, 2, 3, 4, 5, 6. Mic check. 1, 2, 3, 4, 5, 6. Microphone check. YouTube mic check. 1, 2, 3, 4, 5, 6.
Good afternoon. Thank you everyone for joining the briefing. Today, as we prepare for the winter season, I'll focus not only on our latest COVID metrics, but also provide an update about what we're seeing in LA County in terms of flu and RSV, concluding with information about what we can all do to both minimize the impact of these respiratory viruses and get care when we need it. Since over the last several weeks, we've not seen significant changes in our monkeypox numbers, with the number of average daily cases now at around 3 cases a day. We'll no longer give routine updates on monkeypox at our weekly media briefings. Instead, we'll continue to post updates on the monkeypox dashboard at ph.lacounty.gov/monkeypox every Friday. And we'll, of course, provide any periodic updates at the press briefings when there are changes in the trajectory of the outbreak, there's new guidance, or there's new information about mitigation efforts. We are relieved, as I am sure are so many others, to see encouraging trends that reflect both behavior changes and lots of people accessing vaccines and therapeutics. I'll take the next slide. We also continue to closely track COVID-19 in LA County, including daily reports to observe any changes or new trends. So here are this week's updated trend lines for cases, hospital admissions, and deaths in LA County. In this figure, the green trend line shows the 7-day average of the number of cases reported daily, and it's measured using the vertical axis on the left. During the past week, there was an average of just under 960 cases reported per day. That's a small 4% increase from the 7-day average of 920 cases reported per day last week, and you can see that on the green line. We're no longer seeing a steady decline in cases that we've been reporting since July, and these reported case counts appear to be plateauing since about October 16th. While reported cases represent only a portion of those infected, we still pay attention to this trend line and will closely monitor it over the next week to see if the course is changing. Given that hospitalizations are a lagging indicator, we'll also continue to observe carefully whether changes in case numbers have an impact on admission numbers in the coming weeks. This past week, there was an average of 59 admissions per day. That's a slight decrease from the 66 admissions per day last week. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. Like hospitalizations, this is also a lagging indicator, often not showing any change until after hospitalizations rise. Currently, this metric has plateaued. We're seeing about 10 to 12 deaths reported per day. This is both this week and last week. I do want to take a moment to recognize the impact of these deaths. We know that every life lost is profoundly felt by families, friends, and colleagues, and I extend my deepest condolences. I'll take the next slide. Using the CDC's community levels framework, LA County remains in the low community level. This is now the 9th consecutive week. Given the plateauing of cases noted earlier, it will be critical to keep an eye on our weekly case rate, which increased slightly this past week to 65 cases per 100,000. The values we're seeing for the rate of new COVID-19 hospital admissions and the proportion of beds occupied by COVID patients both declined slightly. At all community levels, the CDC recommends staying up to date on vaccinations, including the new bivalent booster, testing if you're sick or you've been exposed to someone who has COVID, and isolation if you test positive. People who are at increased peril for severe disease if they become infected may reduce their risk by taking additional protective measures, even if we're in the low community level, and they're always encouraged to reach out to their healthcare provider for additional guidance. We'll take the next table. On this slide, we have our 8 early alert signals that we consistently monitor to identify potential changes in COVID-19 transmission. During the past week, 3 signals met the threshold for medium concern. This is up from just 1 signal last week. For the second week in a row, the number of new outbreaks in skilled nursing facilities is of medium concern, with those number of new outbreaks increasing this week again to 15 from 13 last week. In the TK through grade 12 school classrooms, we also have an increase in the number of newly opened outbreaks. It's moved from 7 last week to 11 this week, and that moved this metric to medium concern. And wastewater concentrations of SARS-CoV-2 also increased, moving this from low to medium concern. And if we go to the next slide, I'll give some more details on wastewater. On this slide, we show the trends in viral concentrations in wastewater from late May through mid-October. The blue line is a weighted average for viral concentration across 4 wastewater treatment plants, weighted by the population size served by each plant. The treatment plants that are included are Lancaster, Tapia, Hyperion, and the Joint Water Pollution Control Plant. And this covers 75 to 80% of residents in LA County. Following the trends we're seeing with other indicators this week, the viral concentration increased, and as I noted, it's now of medium concern. As a reminder, we're using the peak in viral concentration seen in wastewater during the most recent summer surge as our reference point. Currently, our metric, as you could see, shows that we're at 31% of the peak seen in July. That's an increase from 21% that we saw last week. The increases we're seeing in these 3 early alert metrics are slight, and they are not cause for alarm. However, they do suggest that locally there is no longer a consistent decline in COVID-19 transmission. And this reminds us that we ought to prepare for the possibility of another winter surge. We want to be realistic because every COVID surge brings additional risk. However, we're also optimistic because we have powerful tools, including therapeutics and the new bivalent boosters, that can blunt the impact of increased transmission. We just have to make use of the tools we have. Next slide. Emerging variants and subvariants of the virus have played a large role in driving past surges. And as we try to anticipate COVID trends for the winter, we continue to pay close attention to the weekly reports of circulating virus strains in LA County. The most recently available data show that Omicron BA.5 continues to be the dominant subvariant. Yet each week it's accounting for a smaller proportion of the samples. And you can see that clearly here. For the week that ended October 8th, about 82% of sequenced specimens were BA.5. That's in comparison to 88% the week before and about 92% just a month earlier. There are multiple sublineages of the virus that we're tracking in LA County. Many of them are sublineages of BA.4 and BA.5. BA.4.6, that's represented on the graph by the yellow bars, decreased to 3.3% of sequenced cases. This is down from, I think it was a little over 5% the week before. If you look on the yellow bars on the graph, you can see that BA.4.6 has hovered around 3 to 5% for the past 7 weeks, indicating that this sublineage is not appearing to rapidly outcompete other sublineages that are circulating at this time in LA County. BF.7, shown by the bright blue at the top of the bars, now makes up the second largest proportion of cases sequenced at 4.8%. This is an increase from 3.2% the week before. And just as a reminder, BF.7 is a descendant of BA.5. Last week, we added 2 additional descendant strains of BA.5 to this slide. We added BQ.1 and BQ.1.1. And those are indicated by the pink and purple bars that are at the top of the graph. Both of these sublineages are currently at very low levels in LA County. They account for about 2.7% of specimens combined for the most recent week. However, CDC estimates that as of the end of last week, BQ.1 and BQ.1.1 combined accounted for nearly 17% of cases across the country. And that was up considerably from about 9% the week before. There are reports that BQ.1 and BQ.1.1 have some growth advantages over some of the other sublineages, and therefore they may begin to increase here as well. BA.2.75, that's shown by the pale green at the bottom of the bars, accounted for 1.5% of specimens in the most recent week. This is a slight increase. It was at about 1% last week. BA.2.75.2, this is a descendant of BA.2.75, remains really low, accounting for 0.3% of specimens for the week that ended October 8th. Note that there's only been a total of 8 specimens sequenced as BA.2.75.2 in LA County so far. With the relatively low numbers of recently sequenced specimens of these new sublineages in LA County, there's no one candidate that we can say with certainty is likely to outcompete other circulating strains. However, we have learned that it's very important to carefully observe trends in other jurisdictions and retain local sequencing capacity to assess potential risks. We know that as this virus changes, much of the growth advantage is associated with an ability to evade prior protections, allowing for increased transmissibility. Given that this is our reality, we need to be willing to take common sense precautions to protect ourselves and those most vulnerable from severe outcomes that are still associated with this virus. The most effective step we can take is to boost our immune system with the vaccine if we haven't yet started the initial series, or with the new bivalent booster if we're at least 2 months out from our last dose. Over 7 million people in LA County face waning immunity from their previous vaccine and booster doses. And with few community-wide safety measures in place, more people may be vulnerable this fall and winter. Getting boosted, which for many may be the 5th dose in a year and a half, is likely to help keep many people out of the hospital, and that could keep our healthcare system from getting overwhelmed. Next slide. One reason for the focus on minimizing the impact of a possible COVID surge this winter on our healthcare system is because we're already seeing signs of increased spread of influenza and other respiratory illnesses, both of which create demands on clinics, emergency departments, and hospitals. I want to share a bit about what we know about the current impact of respiratory illness in LA County. Flu and respiratory illnesses are tracked differently from COVID-19, with neither requiring mandatory reporting of cases. So instead of tracking individual cases, we monitor trends in the percentage of specimens that are testing positive for flu and other respiratory viruses such as RSV at Sentinel Clinical Laboratories serving hospitals and healthcare networks across LA County. On this slide, you can see the trends over the past 4 flu seasons, as well as the start of our current flu season. The calendar for flu monitoring begins in October, so this is a little unusual, and it runs through September of the following year. On this graph, you can see the months along the bottom, and the axis on the left represents the percentage of specimens that are testing positive for flu. Of note, in LA County, we typically consider the flu season as officially starting when the percentage of specimens testing positive reaches 5%. When we look back to the 2018-2019 flu season, that's the yellow line, you can see that the season started in December. It peaked around late February, with only around 17% of specimens testing positive at that point. However, the flu season that year lasted a long time, decreasing gradually and only abating in late April. In contrast, you can look at the 2019-2020 flu season, that's shown by the blue line, and it's very different. The percent of specimens testing positive started rising in November and rose sharply, peaking in January at around 36%. That year, the season ended rather abruptly, with the percentage of specimens testing positive for flu dropping to nearly 0 by early April. Remember, that's exactly when we started, imposing COVID safety measures here in LA County. The 2020-21 flu season, that's shown by that flat pink line, was extremely unusual. It was essentially skipped, and that's probably likely because of isolation and other COVID precautions. Last year's 2021-22 flu season, that you can see by the green line, was also unusual. You can see that the flu season began in December, right around the same time as the new Omicron variant of COVID was surging here. The many precautions that went into stopping the Omicron surge managed to also stop flu almost entirely, and the percentage of specimens that tested positive for flu fell below 5% for much of the remaining winter. As many COVID protective measures were discontinued in the springtime, you can see that flu cases resumed, and we experienced a highly unusual springtime flu season after that. As you can see, flu cases began rising again in LA County this past September. The current flu season, which started at the beginning of October, is captured by that small red line off to the left, and it has just 2 data points so far. Although it's still October, we have surpassed the 5% threshold that indicates we're in flu season now, and the amount of influenza we're seeing is increasing sharply. This is the earliest start to the flu season we've experienced in the past 5 years. We don't know yet what this means for the trajectory of the flu season this year, because as you can see on this slide, every flu season, even pre-pandemic, looks different, reflecting in part what strain of flu is spreading, the percent of individuals vaccinated, and the match of the vaccine to the strains of influenza that are circulating. This year's flu season could peak quickly and then decline, or it could be a more severe season than usual, either in the severity of the peak, the length of the flu season, or both. What we do know is that given that flu activity is unusually high right now, getting vaccinated for flu is an important step to take to reduce the risk. Next slide. Many concerns come with a more severe flu season include how the healthcare systems will be affected. This slide shows the percentage of emergency department visits related to influenza-like illness by age group across the last 3 years. Again, starting pre-pandemic, October 2019, through October 2022 of this year. There's a lot of data on this slide, so I'm going to choose one line and try to explain it in more detail. The blue line represents the percentage of emergency department encounters among children ages 0 to 4 that were related to influenza-like illness. You could see that at the far right, in the most recent data of this month, this blue line is moving sharply upwards. The most recent data show that 23% of 0 to 4-year-olds seen at emergency departments have influenza-like illness. Just below it, the orange line represents children ages 5 to 11. The most recent data show that about 17% of 5 to 11-year-olds that were brought to emergency departments had influenza-like illness. For all the years shown on this graph, children under 11 always have the largest proportion of emergency department visits related to influenza-like illness. So it's not unusual that we're seeing this age group disproportionately affected. But what is unusual is that we're seeing such high levels of children in the emergency department reporting influenza-like illness this early in the season. Next slide. RSV is a common respiratory virus that usually causes mild cold-like symptoms for most people. While many people recover in 1 to 2 weeks, RSV can be more serious, especially for older adults and very young children. It can cause inflammation in the bronchioles, or the smaller airways in the lungs. RSV is the most common cause of pneumonia and bronchiolitis in children under 1 year old in the United States, according to the CDC. This graph is set up the same as the previous graph, showing the percentage of specimens testing positive for influenza, in that it begins in October and ends in September, but this time we're looking at RSV. The axis on the left doesn't go as high as it did for the flu. It goes up to only about 16%, since the percent of samples testing positive for RSV is typically lower than the percent testing positive for flu. Here we're looking at the percentage of specimens testing positive for RSV during the 5 most recent flu seasons, including the current one that we're in now. You can see that just as we saw with flu seasons, RSV seasons typically begin in the late fall or early winter, but they vary in severity and duration. The pink line illustrates the 2020-21 season during the COVID pandemic. You could see that RSV was essentially absent until the summer of 2021, when some of our COVID-related precautions were lifted. RSV positive specimens remained elevated throughout the fall, and the 2021-2022 RSV season started very early and at a high level, peaking in December, just as extra protective measures were put in place in response to the simultaneous surge in COVID caused by the arrival of the Omicron variant. RSV remained at a low level through most of 2022 before beginning to increase in September. The most current season of RSV is shown in red at the far left. We're starting at a much higher level than usual. Currently, for the 2022-23 season, 12% of specimens are testing positive for RSV. And as you can see, this is high for October. The current percent of specimens testing positive exceeds the peak that was observed pre-pandemic during the 2019 and 2020 and the 2020 and 21 seasons, and it's on par with the peak of the 2021-2022 season. As with the flu, we cannot predict whether this is an early peak or a start to a severe season. But we do know that RSV activity is unusually high for this time of year and warrants caution. Next slide. The lines on this graph represent the percentage of emergency department visits by age classified as related to RSV or acute bronchiolitis, commonly caused by RSV. The blue line, representing children 0 to 4, is currently at the highest point we've seen over the past 3 years, with 7% of ED visits among children ages 0 to 4 being related to RSV. 7% may seem like a small number, but as you can see from the graph, it's unusually high, underscoring the need for preventive measures to protect children. Next slide. As we see high levels of flu and RSV activity, especially in children, we're also keeping a watch on pediatric hospital capacity. Here you're going to see the 7-day averages for the percentage of pediatric hospital beds occupied from June of 2021 to October 26th of 2022. The blue line shows the percentage of staffed pediatric ICU beds occupied across LA County. This number tends to be, as you can see here, somewhere between 50 and 70%. The yellow line shows the percentage of all staffed non-surge pediatric beds that are occupied across LA County. Non-surge beds simply refers to staffed hospital beds being used when the hospital is at its regular capacity, and it excludes any extra beds that sometimes get added during a surge. At this time, as you can see, we're not seeing a major spike in pediatric bed utilization at hospitals, which is often a strong indicator of whether our hospital systems are overstressed. This doesn't mean that hospitals are not experiencing stress. Given the trends that we saw in the other 4 graphs that show high levels of flu and RSV activity and its potential effect on children, our healthcare staff are very busy. And as always, when there's a lot of respiratory illness circulating, healthcare workers are also vulnerable to getting sick and to needing to stay home to care for ill family members. This again can create additional stress on the healthcare system associated with staffing disruptions and shortages. Next slide. Fortunately, given that we're seeing these unusually high levels of flu and RSV activity, and we saw some indicators that we could be heading for a possible COVID surge in the coming months, it's important for us to note that there are simple actions we can take to prevent and reduce the burden of respiratory illness. First, we can all take advantage of the annual seasonal flu vaccine and the COVID-19 updated booster that's currently available. Both of these vaccines provide updated protection against what we're currently seeing or expect to see in terms of disease this winter. As past protection from vaccines or infection wanes, the bivalent booster and the annual flu vaccine can provide significant protection against severe disease. Second, we all need to remember to wash our hands frequently, especially after coughing or sneezing, using the bathroom, or before preparing food. This is a good time to return to the basics of washing for 20 seconds and making sure you get all areas of the hand, including between fingers and under nails, clean. This is a tried and true way to help prevent the spread of disease, and it's a healthy habit we all need to adopt. If you're unable to wash your hands, alcohol-based hand sanitizer can also be very effective. Next, masks do remain an effective tool to limit the spread of disease. While indoor masking remains an individual preference in LA County, We do know that a well-fitted, high-filtration mask will provide protection against respiratory illnesses, helping to block droplets that are in the air. And for those more vulnerable to severe illness from respiratory viruses, masking remains a good idea. Importantly, we ask that you please stay home if you have symptoms of respiratory illness, including coughing or sneezing, a sore throat, headache, muscle aches, or a fever. Test for COVID, and if you have persistent or significant symptoms, check with your healthcare provider as soon as possible, since they're able to provide additional tests and appropriate treatment for flu and COVID, and for children for RSV. Next slide. If you or someone in your home is sick with flu, COVID, or another respiratory illness, it's important to try to remain away from others as much as possible. When you feel sick, and especially if you have a cough, consider wearing a mask around others if you cannot isolate at your home. If you test positive for COVID-19, LA County requires that you wear a highly protective mask when around others until you end your isolation. It's important to stay hydrated by drinking lots of water, broth, herbal teas, juice, or other liquids. If you or a child is vomiting or sweating from a fever, this is especially important. Over-the-counter medications can help manage a low-grade fever or mild symptoms, but always feel free to check with your provider to see if this is a good option for you or your child. It's also good, as we noted, to frequently wash your hands and disinfect and wipe down surfaces, especially in high-touch areas. This can help to protect other members in the household, and it's a good practice to keep up throughout the winter season. Next slide. Respiratory illness symptoms can become severe, and they can become severe quickly, and you should not weather them on your own. If you're feeling very unwell, please do not tell yourself that it's just the flu or you think it's not that serious. Treatments for the flu and COVID-19 are available by prescription. The following symptoms can indicate a more severe infection and a reason to see a doctor: any difficulty breathing, persistent chest or stomach pain, significant vomiting or dehydration, severe weakness or muscle pain. For children, there are some additional symptoms to keep in mind: a fever greater than 104 or a lower sustained fever paired with other concerning symptoms, fast or troubled breathing, a bluish discoloration of the skin. This signifies that there may be a shortage of oxygen in the blood. A shortage of tears when crying, reduced urination or confusion, which are pediatric symptoms of dehydration. Greater irritability or not wanting to be held. Parents and caretakers should never hesitate to call their pediatrician if they have any concerns about their child's health. You know your child best. Trust your instincts, ask questions, and seek care if you believe it's needed. If you need help finding a provider for yourself, your child, or any other family members, you can call 211. Even if you're not insured, the LA County Information Line will provide information about options that are available to you. Please don't wait until symptoms are severe before accessing treatment and care. In closing, it is important to remember that viruses are part of the natural world. This is not something we can control, but it is something we can prepare for and plan around. Be aware of symptoms, stay home when you're sick, and make sure you're taking advantage of the powerful vaccines, tests, medication, and other resources that are available. I hope that everyone enjoys the upcoming weekend of fun Halloween activities and has a chance to gather with friends and neighbors. This is a great time of year, and we're fortunate to be at a place where, with some planning and attention to common sense safety measures, we can resume many of our customary celebrations. Test before large indoor gatherings, stay home if you or your child are ill, and as always, make sure that costumes are safe, dispose of unwrapped candy, and remain on sidewalks and use crosswalks when trick-or-treating. And all of us should keep an eye on children enjoying the festivities in our neighborhoods, taking care when we're driving and supervising activities where children are present. Next week, Dr. Davis, the health officer for LA County, will be presenting at the Board of Supervisors meeting on Tuesday, November 1st. This meeting is open to the press. For this reason, there won't be a press briefing next Thursday, but we'll resume the normal schedule the week after. Thank you, and I now can take your questions. I'm also here with Dr. Balter, who can help answer questions about respiratory illnesses circulating in LA County.
Questions? Marlon?
You have no questions? Okay. Hi, Dr. Ferrer.
Hi.
Thank you so much. Let's see, where do I want to begin? Well, with the RSV, because I did a story on this earlier this week, and I appreciate the statement that you provided then. I understand it's not a trackable illness. I think
It's not trackable like we track reportable illnesses.
reportable. Okay.
Right, so it's not a reportable illness, so that makes it more difficult for us to keep track of it.
We have heard from a lot of parents who are now concerned about RSV for their children. So
Yeah.
what is your message? Do we know why that we're seeing this spike right now?
Well, we've seen spikes before. So, I mean, the first thing I want to say is we had a lot of RSV last year. I know there's some people saying, oh my gosh, we had no RSV for the last 2 years. It's actually not true. And that's why we shared the data. And that's why we also shared data pre-pandemic. So people can see that respiratory viruses, some years where they hit us hard, and some years we seem to have a much milder season. And I don't think there's a definitive answer, but I will ask Dr. Balter, but you'll have to come up, Sharon. Because she can just talk about the variability that we see always. I mean, not necessarily because of the pandemic, like respiratory illnesses, as I just showed you. Some years we have terrible flu seasons and some years we don't. Certainly some of the protections we took for COVID worked particularly well for flu. I mean, all of the sort of mask wearing for flu that, all of the mask wearing we were doing for COVID really kind of made it very difficult for flu to spread. Now, you can see right away when we stopped wearing masks in March, we had a peak of flu cases, highly unusual for us. But again, these masks work pretty well against many respiratory viruses.
Yeah, I mean, I don't know that I have a lot to add. I do think that people are more aware of RSV this year, in part because we're more aware of respiratory viruses. This is not a bad thing. I think we're also all concerned that there will be, a lot of respiratory viruses, and in the same way that we've worried about overwhelming our hospital system in previous years just because of COVID. This year, luckily, we have way more things to help us manage COVID, but we're also aware that there are other things that can strain our hospital system together. But yes, both RSV and flu, they vary a lot from year to year. And the main thing, the message for really all three of them is to be aware, especially for people who are vulnerable, and not to hesitate to call your doctor. Particularly for flu and COVID, we have good treatments available, but even what we call supportive treatment, if somebody is struggling with a respiratory illness in the hospital, can be incredibly beneficial. So just to keep in touch with your provider. And if you don't have a provider, now would be a great time to get.
And then given that we talk a lot about flu, is it fair to say that you're more concerned now about flu than COVID? And are we getting closer to the end?
Well, I'm going to always be concerned about illnesses that are easily spread in our community. And I don't think I would pick one that I'm more concerned about over the other. COVID, as we've shown over and over again, is a very deadly and dangerous respiratory illness, easily transmissible. And with all of the mutations, one thing that stands out for us is that it just seems to get more and more infectious, more easily able to transmit to other people. So we're going to continue to, of course, urge that people take advantage of the precautions that are available for COVID. I mean, we're so lucky to live in this country where we have sort of ample access to one of the best protections against serious consequences of either influenza or COVID, which are, making sure that we're getting our vaccines. So we like to make sure everyone understands, we're not helpless here, and we're particularly not helpless on trying to really dampen the impact that a lot of transmission can have on our healthcare system. What we're trying always to avoid is overwhelming the healthcare system, along with trying to avoid unnecessary illness and death. And the way to avoid, for all of us, and none of us want an overwhelmed healthcare system. We've been there twice now, and it has other consequences. And, we have better tools this year. I mean, we're going in with a good booster that's actually matched to what's circulating for COVID.
How is the demand for the booster? Because I know it's been
Where
extremely low.
it is low. Again, it's low enough to be concerning. We're up at about 10% of eligible people have gotten boosted, so we're doing a little bit better. I know we're doing better than other parts of the country, but we're nowhere near where we need to be to actually enter into the colder months, the holidays, with that sort of additional layer of community protection. I did spend a fair amount of time the past couple of weeks talking with folks, some at our pods, some at events I was at, and I think we have to do a better job communicating about this bivalent booster. Many people hear the word booster and they're like, I got boosted. I got boosted, whatever, last year, and they don't hear any message from us clearly enough that says, A, if you're 2 months out from your last dose, it's time to come back and get a new dose. And they also, I think, appropriately are saying, I've had 2 boosters and I got infected. I feel pretty protected and our numbers are relatively low. So I think the combination of there being confusion about like how many boosters do I need, and many people in our county, we're up to about 82% of people over 5 being fully vaxxed. Many people have taken advantage of the protections. They still might have gotten infected, but they feel very comfortable that they're in a place where there's not serious risk from COVID.
I have a couple more questions.
Yeah, and then we'll go to Ron.
Okay.
Since you're still talking about the bivalent booster and the messaging of it, so did you see the president's tweet today? He put out, he put it out and it says, one shot once a year, that's it. And then, we're 5 shots in a year and a half, so it's confusing. So is that from the CDC that it is, we're gonna get 1 shot once a year like the flu?
I haven't seen any guidance come from the CDC yet. And of course, we are a public health department, so we'll wait to see what the guidance is from CDC. I know that we all hope that's where we're headed. So I think we would like this to be a very similar seasonality as we face with the flu vaccine, where we all come in once a year and we get vaccinated, and that gives us a lot of good protection for an entire year. I think we'll wait until we get direction from the CDC, and we're anxious always to see the studies. I want to say that because this is a relatively new disease, even though it feels like forever for us at this point, it is important, particularly because it's a coronavirus that mutates a lot, for us to have some patience and get the researchers and their studies in before we make a definitive claim that we're moving to once a year. But I do agree with the president that that is what we're all aiming for. A much easier schedule for everyone to line up behind.
So is it then that perhaps the president sent this tweet out sort of more as a hopeful tweet as opposed to...
I haven't seen the tweet, but...
if he's the president of the United States and he sends
Yeah.
this out and you're not even sure if that's the message.
Well, I mean, I haven't seen the tweet. I will say that President Biden has been, super supportive of us as a community coming together and taking care of each other and getting us together collectively through the pandemic. And I appreciate the emphasis on trying to reassure people that we're not in this forever place where people are going to come within the space of a year and a half and need to get 5 shots. Because I think people are exhausted by that reality. And I think we're all feeling very hopeful that as our vaccine technology is improving, there's going to be both a good match and the ability for us to be very targeted around coronaviruses. But I haven't seen the tweet, but I will wait, like I think all good public health people will, for the guidance from CDC, which really then summarizes the studies and the research for us and gives us all some certainty in the direction.
Yeah, I did have the last question would be, perhaps you saw the latest from the LA County USC Medical Center, their virtual town hall, where the doctors basically are saying that we're so low in COVID cases.
Yeah.
We had 0 in 24 hours, 0 positive COVID tests out of 125 tests completed. We haven't had that since April. Can you explain sort of the difference on the numbers that you present versus that one hospital within the county?
I don't think the numbers are so different, although I don't really know of other hospitals that are saying, you know, I had 0 cases, 0 people testing positive in the last 24 hours. I mean, our hospitalization numbers are slightly below 400, and that comes from almost 80 hospitals. That means that at any given hospital, the number of patients that are there positive with COVID, whether it's incidental or that's what brought them to the hospital, is very, very small. And it also means that if then you look at sort of the proportion of those cases that are incidental, remember, we're still at about 60% of folks at the hospital who have a positive test. It's incidental to the reason why they're in the hospital. You can see why the numbers of patients receiving care for their COVID illness is way down, and we're grateful for that, and we don't think that's unusual, that hospitals are now starting to say, you know, haven't seen anything for 24 hours. I mean, we would like for us not to start going back up, because, you know, a couple of weeks after cases go back up, historically, we've always seen some small increases start in hospitalizations. But I think we all share in sort of the relief that hospitalizations are down. As I noted, I think they're lower than they've been since last April.
Thank you.
Just a couple questions sent in from Ron Lynn at LA Times. Are any variants emerging to you as the one to be most worried about, or not really? The second question is, the death data you released last week shows that the COVID death rate for Black and Latino residents between January to June 2022 remains significantly higher than for white and Asian American residents. Has that disparity persisted during the summer Omicron wave? And are you concerned this disparity will appear again this winter? And then the last question is, some have talked about the possibility of a triple-demic, given COVID, flu, and RSV. Given that, are you considering reissuing a universal recommendation for mask wearing again?
Let me just take the last one so that I don't lose it because I didn't write it down. But thanks, Ron. You know, we have laid out the guidance for recommendations around mask wearing, and we've tied them very closely to the CDC community level. We do appreciate that with increased respiratory illnesses that are spreading in our community from, you know, in particular influenza and RSV, that guidance that's clearly, you know, using a framework that assesses the risks associated with COVID may not be as complete as we're going to want it to be during this upcoming winter season. But I will say with certainty that we will not be moving towards universal indoor masking as a requirement until we reach that high level as we've designated in our planning documents. So I know there's questions about will we need to do a better job on recommending that people go ahead and, you know, put their masks back on. You know, right now it's individual preference. You can hear us already saying, with this much respiratory illness circulating, people who are concerned should take that in account, even when the decision is made by individual preference. You know, these masks, as I noted, work particularly well against influenza. So folks who who have had bad flu, are at risk should they get infected, may want to go ahead right now and start putting masks back on, and that's fine. Will we go ahead and assess and maybe move from individual preference to a strong recommendation that people mask up indoors again? We'll have to keep looking at our data and assessing the risk, but I do want to make a commitment that the move from recommendations to you know, sort of a universal indoor masking is going to remain as it's stated. I mean, obviously, should the state do something different or CDC do something different, we'd have to take that into account. But based on what we're hearing right now, I think people can feel pretty confident that what we're going to do is what we've been trying to do all along, which is give you really good information about where the risks are and allow you at this point to understand the benefits of the protections that are available to all of us. And that includes obviously vaccinations and boosters as well as mask wearing. And, I want to say with respiratory illness, please, 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 please stay home if you're sick. They're easily spread, and if people who were sick would stay home, we would really reduce risks of transmission. In terms of the second question on disparities, persistent disparities would be the way probably to think about this among people of color, Latinx, and our Black residents in particular. It's sobering and it requires continued attention from all of us. We appreciate, we saw in the Times an article about overcrowding, again, that I think really highlights what are some of the drivers of the spread of infectious illnesses. And we think there are others as well. We think the lack of health-affirming resources in some of our communities plays into this, and it's resulted in a higher burden of chronic illness amongst African Americans and Latinos and Latinas. And that means, never, not for a minute, not for a day, forgetting our obligation to actually address those equity concerns and continue to fight to narrow the gaps. Certainly around COVID, a lot of that work has been around making sure that information and access to things like vaccines and therapeutics are available everywhere with as few barriers as possible. But I think we have to work with others to address some of the root cause issues, and we're going to continue to do that. I do want to note that those gaps get wider every time we go into surge. So if you look at our data and you actually divide it somewhat differently, and you look at periods where the county is experiencing surge in COVID cases, and of course after that come hospitalizations and deaths, that's where the gaps get the widest. And in fact, that's been experienced in other parts of the country as well, which really leads us back to paying a lot of attention to the increased risk that people have because of their exposures. So if you have more exposures during a period where there's a lot of transmission, you are going to be more likely to get infected. We've already shown you multiple times that while vaccines protect everyone, the protection for vaccines varies both by race and ethnicity and varies by place where people live. People that live in communities where there's lots more people of lower incomes, even if they're fully vaccinated, do not have the same protection as people who live in well-resourced communities who are vaccinated. We've looked at that by hospitalizations, we've looked at that by deaths, which really says, another place to focus is on trying to reduce those exposures. Some of those happen at workplaces, some of those happen in community, and unfortunately, a lot of it happens in overcrowded housing situations where people cannot really separate themselves from each other. In terms of the question on variants, across the country, there's a lot of concern about BQ.1 and BQ.1.1 because nationally, they observed a doubling in a very short period of time. And we need to pay attention to that here in LA County. We have very small numbers at the moment, as I showed, very small proportion of our specimens that are sequenced are BQ.1 or BQ.1.1. But when you see evidence in other parts of the country that show a doubling, a very quick doubling, then we're going to pay a lot of attention to that here as well. But as I noted, if you look way back over time on sort of the trajectory around variants, particularly with Omicron, you'll see that we don't usually go weeks and weeks and weeks with very low numbers for new variants that are popping up without those new variants either becoming, disappearing entirely or starting to dominate. But we've now seen weeks where, as I noted, BA.4.6 has remained relatively, somewhere between 3 and 5%. So it's hard to say, what in particular we should pay attention to. Sorry, I do want to note, but the most important takeaway for me is we have to pay attention to all of it. And we have to retain our sequencing capacity for LA County.
Need some water.
Any other questions?